Good afternoon, everybody. My name is Garrett Schmidt. I am the managing editor and CEO of ACOExhibitHall.com. And I'd like to welcome you all to today's live webinar by Mozaz called Highly Personalized Patient Experiences, the Key to an Effective Engagement Strategy. And this is going to be a really great webinar. I've heard the preview of it already, so I'm excited to hear from these guys today. So thank you for joining us. A couple of items of note before we get started. All attendees have joined the webinar today in attendee mode or listen only mode, so you don't need to worry about muting your microphone. That's been done for you. The webinar is being recorded, so what's going to happen is afterwards, I'm going to send everyone who's registered, even those who weren't able to attend today, a link to the recording, and so they'll be able to actually watch the recording and download the slides and engage with our speakers there. So we hope that you share that with colleagues, and if you want to, reference that again, we hope that you do so. So I will send that out later in several hours following the presentation. Lastly, during the webinar, we want to hear from you. We're going to have a Q&A session, and you can submit your questions at any time. You don't have to wait till the Q&A to do so. Using your control module, that there's a little area for questions, not the chat, but there's actually a question section that you can submit questions there. So, and if you wanted to pinpoint either of our presenters to ask them directly, then go ahead and specify that in the question, please. And if we're going to get to as many as we can during the allotted time today, I think we can. And if we don't, though, for whatever reason, if we go over, if we're not able to get to your question, just know we're going to follow up via email afterwards. So we'll make sure to get your question. And actually, Keely Truel from the Mozaz team is going to come in at that time and is going to help us with facilitating the Q&A. So you'll get to meet Keely at that time. But at this time, I would like to introduce our speakers today, Dr. John Fraunfelter, who's the CMO of JVon, and Mr. Rini Gahir, who's the CEO and co-founder of Mozaz. So welcome to you both. And I believe Dr. Fraunfelter is going to kick us off. So welcome, Dr. John.
Thank you, Garrett. We're really excited for this time with you today. Good afternoon and good morning to those in the West Coast time zones. And we are going to be talking about some concepts that are a little more cutting edge around how to personalize patient engagement, and then the way to leverage and scale that to your entire population. So we're really excited about the time and the topic today. Keely, we can go ahead to the next slide. A bit about myself. I'm a physician, med-peds trained originally, and I've been in health IT leadership roles in organizations for over 15 years, including Henry Ford Health System and Unity Point Health. And I've been the Chief Medical Officer with JVon for the last 6 years. Rini?
Great, yeah, nice to meet everyone, and we welcome you to this webinar. I'm Rini, co-founded Mozaz close to 9 years ago. I've been in digital health for 25 years now, and so in various aspects and sort of various incarnations of digital health back in the day, but background is health informatics and mathematical sciences around healthcare. Spent a lot of time at Microsoft as various other organizations focused on digital health transformations. But at Mozaz, we help work with organizations in taking a consultative approach to virtual care and digital health, and focused on sort of patient engagement models. And we'll be sharing some of the best practices that we've learned and we've experienced over the years with you today.
So we're going to journey through the agenda here and talk about some patient engagement challenges and an approach. If we understand our patients better, then it will help us to personalize the patient experience. And that's one of the concepts we're going to be digging into. And then how do we go from understanding our patients as individuals and then scaling that approach to the entire population is a second challenge. And then lastly, okay, we do that, but how do we manage for those patients that change dynamically or that don't fit into a typical approach? So thinking through that. And of course, we want to learn from you as well. So we're going to be looking forward to dialogue and discussion. And as Garrett said, please submit your questions and have them ready at the end of our conversation as well. So let's get started. And when we look at patient engagement today, it's obviously important. Patients that are engaged are more informed in terms of the decisions they make. They're participating more in their care. Disengaged patients, we know, are far more likely not only to have unmet medical needs, but to even be neglecting their own care. There's risks for delaying care. All of those things we know inherently to be true. What are some specific reasons why and examples why patients might have challenges in getting engaged? There are some barriers to patient engagement. Health literacy, it's surprising that the reading levels and education understanding levels of health literature, that there are gaps there, and health systems, you know, we've worked at 6th grade level and then 5th grade and then 4th grade reading level, and there are still challenges even in terms of folks understanding. Along those lines, it's not just the written word, but it's also the spoken word. When you've got a significant amount of population with English as a second language, and there are challenges when there are language barriers to understanding even how to access care, what to do next. Even the conversation around scheduling an appointment becomes a challenge. And then you convert that fluency to digital. So you got written, you have verbal, and then you've got digital fluency as a third opportunity, but also a challenge. And in digital fluency, it's not just the older generation. There are individuals in every generation that have challenges with technology, digital fluency. And as we shift more to those types of modalities, understanding who the patients are that are particularly challenged there is important to understand. And then a fourth example, and these are not comprehensive, but these are examples of barriers of patient access. And this is both from a geography standpoint, whether it's remote also, do they have digital access even, or if it's in person, do they have transportation? And all of these factors combine together to create the experience for the patient. Sometimes those experiences are good, sometimes they're challenging. So we have a poll question for you, and go ahead and put the question up, Garrett. And as you're putting the question up, we'll just chat a little bit. Our interest here is there's a whole spectrum that organizations are on today in their journey of defining patient engagement, measuring it, getting to successful outcomes. So just identify where you are on this journey.
Hey, John, how would you define patient engagement?
Yeah, well, it's interesting. There's the patient-centric lens around the barriers for patients and challenges that they have, and then there's even the provider lens as well, the other side of it. When providers are too busy to provide literature, for example, that becomes a challenge. I don't have a good documented definition, but I would say patient engagement, my definition, is a patient that's actively understanding and participating in their care and in decisions about their care.
Yeah, I think that shared decision making is a big piece, and just that active sort of participation in their care, right? So that does become big aspects. And what we see is obviously the more active a patient is involved with their care, typically the better the outcomes are, and both for a financial and sort of from a health outcome. And so the goal is to drive up those activations, to drive up that engagement level in various aspects of their care.
Well, we also know it's increasing in importance as there's more competition, and patient engagement becomes a form of loyalty as well. Garrett, are we getting a good amount of responses there with the poll?
Yeah, I think we're about ready. Let me go ahead and pull up the results here.
All right. Well, this is great. This is insightful. There is, and not terribly surprising, the journey is early for a lot of organizations around how do we even define what we're going to do. And obviously, you need to define it before you move forward to attack a problem and solve it and measure it and define success, and then showcase it, obviously, or ideally in a market that is searching for answers here. So definitely opportunity when folks are early in the journey to begin thinking about this. Rini, any thoughts on this, on the poll results here?
Yeah, I would also say that patient engagement is in transition, right? It's evolving. So we might be at phase 3 of what patient engagement really is. I mean, we started off with patient portals at the beginning, and various sort of aspects of the patient portal. But now, as organizations still struggle to drive engagement with their patients with the existing technologies, there's fundamental things that really need to be looked at or optimized to really help drive engagement. And so even though the word patient engagement has been around for a while, and various technologies have been around for a while, there is still a big challenge in driving engagement and retention with organizations and their patients. And so the maturity model around patient engagement has evolved, which is good. But there's a lot of ground to cover in helping organizations get to that level.
Yeah, well, it is challenging. So if we go to the next slide, here's from the patient story perspective. I see it as, I'll call it the patient engagement gauntlet. If they can survive the gauntlet of these barriers and challenges, then on the other side of that is a patient that's engaged in their care. But along the way, you can see accessibility might cause them to drop out, and they're on the journey, and we're attempting to engage with them with digital technology, and they're not interested or not able there, and they drop out. Or another patient with language barriers, and then the last one, again, as we've touched on with health literacy, any of these things along the way, and they hit that barrier and they drop out of this path, and then you have that smaller percentage on the other side that is actually engaged, and that's unfortunate. These are barriers that if we understood them, not at the population level, but at the individual level, we could do something about it differently. That's the idea. So how would we do something differently about it is an interesting question we're going to dig into. Let's go to the next poll, and Garrett, if you can tee that up. And very interested to see the responses to this is in terms of thoughts on the biggest barriers to patient engagement, and there might be others as well, but this is a starting point for beginning to tackle this. If this is a problem to solve, defining the problem is pretty important. Rini, what have you experienced in the work that you're doing there with Mosaz?
Yeah, I think there's, even within a single patient cohort, there's so much variability and so much individuality within those patient groups, and it's hard to understand all the sort of nuances or specifics about those different patients. So, from our experience, a lot of the organizations, a lot of the clinicians, they don't know this information about the patient, right? This is a big gap. They may know, the patient's demographics and diagnostic information, but they don't really know a lot of the other sort of social factors and sort of health literacy levels that these patients may experience. And so a lot of this is unknown from our experience.
Yeah, this is a new. I wouldn't call it quite a frontier, but it's a new challenge for healthcare, is really understanding patients well enough to interact and intersect with them in a way that's relevant to them. I'm trying to avoid the phrase meet them where they're at. I'm sure no one's heard that before, but interact and intersect with patients in a way that's highly relevant to them is the challenge for all of us. Gary, do we have results there for the poll to take a look at?
Yeah, let's go ahead and take a look here.
All right, accessibility certainly surfaces as a high area of focus. And then if anybody has comments on other, please put it into the chat or bring it up or raise it as a discussion question. Really interested to hear other perspectives on what those challenges are that you see. Certainly we see accessibility, whether it's digital accessibility or geographic, and it could be transportation. Another form of accessibility would be even can't get an appointment for 3 months with the doctor. So how can I be engaged if it's hard? I feel helpless and powerless. So there's a lot to unpack there, of course. Any other thoughts on this? And then we'll keep moving here.
Yeah, no, I think the accessibility, that's consistent. It's consistent with what we see. So location, access to care, as well as, not everyone's comfortable with technology, right? Or a phone app. And so what's the best way to connect with that patient, leads to accessibility challenges. So, yep, it's consistent with what we see.
All right, so moving on then, the premise for some of our conversation and logical thinking, logical path here that we're on is that the drivers of these of health outcomes we know are not clinical oftentimes, and the same is true and particularly true with with patient engagement. And we can go ahead to the next slide. Hopefully it's not stuck on my screen. There's a one before that slide I'd like us to take a look at. It's there we go, non-clinical factors. Maybe it wasn't in sync on my screen, but you can see here, and this is well established for the last decade or so, but this was new thinking after I got out of medical school and was taking care of patients, and then suddenly this concept of social and environmental factors and people behavior factors is a major driver of health outcomes. And if we can better engage patients, we're touching on that 40% orange category, the individual behavior and getting patients more motivated or activated, these different phrases. In the end, what I'm rendering in terms of clinical care is less significant in terms of the whole picture of what's going to ultimately happen with that patient. It's kind of hard for a physician to swallow, but the reassuring thing is it doesn't all depend on the clinical care rendered them, but we have to take a look at these other factors. Now, the idea is if we know these patients well, then we understand what their individual drivers are, and perhaps then can even tailor care, tailor engagement paths to the individual. But it requires first, as a basis, recognize that these are major contributors to the health outcome, even for patient engagement. So what are some of the socioeconomic factors and features that we would look at with a patient? And on the next slide, we'll see the approach that Javion has taken is to take a tremendous amount of non-clinical data, socioeconomic data. And you can see here behavior across the top, in addition to the first two, which are more clinical and provided by providers and payers, that clinical perspective. Then there's behavioral data, environmental data, lifestyle data, transportation, there's housing access, food access, even climate and weather. Third, you see that last category down there on the bottom, third-party purchased is all kinds of stuff that's available if you purchase it, and you have tons of data. So great, you get more data, but the hard thing is to take that down. What a lot of organizations are doing today, they're getting data and then they equate a fact with risk, and that's a fallacy. It takes really intelligent data science to take all that noise and to get the signal out of it, to say these things are true, but these are the drivers of risk for this patient. And so Javion has taken, in particular, the data sources here and translated data into intelligence. So if we, on the next slide, now this allows us to understand an individual, to say this patient, and here's a combination of the clinical data and socioeconomic features, and I'll say non-clinical features that include even some of their preferences, their fluency, all of the things we can know about that patient from a healthcare perspective. And they end up creating a whole picture. Think of it like a high resolution TV versus one of those old monitors in the 80s. If ever anyone had one of those first Apple computers and those block resolution pictures, and trying to see if that was a human being or a tree on the screen. We have much higher resolution now in understanding patients than we did even 5 years ago. And that resolution is a combination of all of the data that's available today, but also the power to interpret it. So we have an understanding, you almost get a persona of a patient, and understanding who they are and what are the drivers, and then you apply data science to it and you say, well, these are outcomes we're trying to look at, and you have the whole story, the whole clinical story of that patient. So on the next slide, as it relates to patient engagement, now you take all of that and say, I want to understand how to engage this patient, how about when to engage them. What are some barriers to engagement that require us to understand and remove those and address those? And it becomes very specific and relevant then to this patient that's got challenges in getting engaged. And it could be because we're engaging, we're trying to touch them in a way that's not relevant, or or perhaps even during their workday, and they're more available in the evenings. Preferred way to be contacted or approached is a relevant question to ask. And these are not unanswerable, and neither, well, there are two ways to do this. Some organizations today are going to these intensive surveys that drain resources, which we don't have, and also take the time of the patients, and they get impatient, and then they either don't answer or they don't take the time to answer thoughtfully. So if we can know these things without draining resources, it becomes really valuable. And I'll turn it over at this point to Rini. Let's take this as a premise that we can and we do understand these patients holistically, and some of the things that motivate them and ways to intersect with them or interact with them in the most appropriate way, the relevant way for the patients. And then what do we do? And Rini will pick up the story there.
Yeah, no, thanks, John, and it's very relevant. So now that we have a better understanding of the patient, we have a lot of insight around that patient, and now we have to figure out the how. How do we make this actionable? How do we get them to engage? How do we help that patient connect to their care, right? So, what I call intelligently assembling all this information for the patient, and then mapping the right personalized digital interaction is an important concept, right? And a tough concept to crack. But once you do that, utilizing and harnessing all this information you have around the patient and figuring out the right mechanism to connect with that patient and the right timing, can lead to successful engagement and retention with patients over time. So, again, just as you mentioned, what's the best way to engage with that patient? We can get a clear understanding and picture on how to do that. Is it through a phone? Is it through a web application? Is it through, maybe it's a letter, maybe it's a phone call still, right? It doesn't have to be digital, but at least we have a better understanding what works for that type of patient. Language is one of the barriers that you mentioned. What language do we need to communicate the intervention or the communication with that patient in? Is the content relevant? Is it timely? Where are they in their path and their journey, right? So the content's got to be relevant, otherwise it's not really going to be used. So we got to look at all those different steps and kind of knock down the different barriers to adoption, the barriers to using an application, right? The more barriers there are, obviously, the quicker people will drop off and not use the technology, and it becomes a failed project. So a number of things to look at, including, how do you help encourage a patient who is now engaged to follow their care plan, right? Care plan adherence becomes very, very interesting. And a lot of neat little modern digital tools that can encourage nudges or automated reminders or points and rewards can be utilized to drive positive behavior change. And so, looking at all these different models, that could be tailored to that specific patient interaction is a lofty goal and is a tough one to crack. Slide 13, Hilly. Great. So the idea is, once we understand the digital profile of the patient, the job then is now to model all the different tools, the different assets, the different interventions, interactions that map to that personal profile. And this is where, obviously, it's challenging, but this is where automated technology can help solve this problem. The best practice approach that we've seen in our projects and in our implementations is where we assemble these digital libraries, if you will, around various content, interventions, resources, and tools. So there's a library of content, a library of digital assets that get created, and that needs to get created, right? And they kind of live in that library. The next thing would be then to create these automated workflows or these rules that can assemble the different assets and snap together the different sort of interventions and content pieces based on defined rules that map to that patient's profile, right? So you can have something that's really customized from a standard stock library of assets that still is more personalized in terms of an experience than not having such a system. Again, a powerful yet a tricky concept where, when we start looking at automating dynamic personalized content based on the patient profile, automating that becomes, is a tricky concept, but can definitely be done. So basically, what we're looking at is using technology to automate the workflows, and based on rules that can assemble all these different assets to create a meaningful engagement encounter. Next slide. So as you can see here, as an example, the digital assembly or snapping together various components from different libraries. So as an example, we may have several different libraries here, language libraries for different sex, age groups, trackers, content, disease programs. All these libraries have various assets and tools that belong within these libraries. Based on this patient profile, we know their diagnosis, we know what meds they're on, we know their social factors, their language, primary language. Based on that profile, using some rules and some workflows, automatically pick the right pieces from the different libraries and stitch together the right content model that could be delivered to this patient, either through a phone or through a web application, whatever medium makes sense for this patient. Can be delivered for a meaningful engagement. So again, making content relevant, making it timely, making it personalized the best we can. That, from what we've seen, leads to a higher probability or higher success rate in terms of engagement and retention in patient models. Next slide, please. So with all the different variations in patients and really looking them as individuals, and with the ability to use data intelligence to really stratify and sort of group patient cohorts, and then mapping this digital content to the different sort of personas. This helps with scale, right? This helps organizations scale to a larger sort of population level where everyone is still treated as an individual patient. So grouping patients by persona, grouping them by various profiles, by age groups maybe, or by disease category, you can start to model effective digital programs that have the ability to scale, because it's without scale, then it becomes a very impractical program and it becomes hard to manage. So looking at practical and sort of models that can effectively and efficiently grow is a key component to a successful program. So in this example, persona number one, involves a group of patients that perhaps have low access to transportation. They have a high risk of readmits, but they have high digital literacy. So most of them probably are used to using smartphones and use mobile apps daily. We can capture that information in a profile. From the type of stuff that Javion does, right? From the data model that Javion can put together. So in this case, then, the system should model content that perhaps is a phone app with app-based digital tools, perhaps some remote patient monitoring type tools, low touch type tools, symptom trackers, in-app secure messaging. That type of group of individuals would have some specific tooling in a specific sort of app platform that would be meaningful to them, right? Persona number two could be a different group of people who have low health literacy, they have high risk of non-adherence to the care plans, and they have medium technology skills, right? In this case, perhaps SMS text messaging is the best medium to connect with these individuals, and using a web application versus a smartphone. And so again, you can tailor that application within that program for that type of persona. And then persona number three could be patients who live in rural areas where physical access to care may be limited, and they have a high risk of progressive deterioration and perhaps low digital health literacy. In this example, individuals require a higher level of touch and support, so perhaps through email or phone consultations, making it easy for them to connect through a phone call or a video consult. Web applications for self-help information could be the right medium for them. So the point with this slide is, even within a single program, you can have, and you should, kind of stratify your groups by persona and model content that can help, drive engagement with the different personas, with the different groups, and that can all be sort of data driven and automated from various workflows and rules.
Rini, can I add a comment here?
Yes.
There's there's such a rich story in this slide. We talk about concepts like demand matching and risk stratification. Demand matching can be translated to this. Risk stratification cannot, because this is more than just applying risk. This is really understanding patients, and based on that, segmenting them. I would describe this as almost persona matching. And
Yeah.
you have 3 examples here, but this is where the power of AI can provide 20 or 50 or however many are worth segmenting in terms of personas, and then connect to an automated platform such as Mosaz, then can put those on, although you've got one platform or one program, but patients are then getting tailored and personalized experiences in how they're engaging with the health system or with the provider, with your organization. And at that point, patient engagement not only has a better chance of success, but it feels good to the patient.
Yeah, really good point. And we've seen programs where where 25 to 30% of the patients in a specific program would have the technology skills or the digital health literacy to use a phone app, right? And so previously in the olden days, you would only target that 25 or 30% group to with a digital health sort of application. But once you start doing persona-based stratification, persona-based profiling, and you look at the other technologies that can reach the other 30, 40, 50% of the patient population, you've just expanded your cohort, your digital health cohort, and driving new experiences with those folks who may have been untouched previously. And so you're providing more meaningful encounters. And we really saw this with the pandemic, right? So with the pandemic, where you're forced to go virtual, you're forced to go digital, really tailoring the right sort of technology, the right medium, the right content to the individuals really provided positive response rates. Next slide. So the ability to respond to data that is collected is obviously powerful, right? What you collect, you can measure, you can act on. But extending this to triggering actions on data that's not collected, or the exceptions, is just as important, right? So as an example, if there's a decrease in app usage over time, but yet the individual symptoms are still getting worse, or they're still have talking to their practitioners or the clinicians frequently, but they're not using the app as much, or there may be some lack of interventions that are getting completed. That's where looking at the exception type model becomes very powerful. Perhaps triggering, you can automate a trigger to provide additional assistance through a phone call, or an intervention to remind them to do an in-person visit, or even a video call, or some other self-help resources to help them get back on track, and help them to use the technology, to use the tools, so they can have better connected care. So for example, we see this a lot. So if a patient misses a weekly check-in, or in reporting a medication or some symptoms, just by them missing that scheduled reminder, this could prompt a nudge, or it could prompt a reminder or an alert to someone on the care team, or even to a family member, or to that patient, to see if they're okay, and to help them get back on track. So again, this also becomes really very useful when it comes to consent forms and various sort of digital documents that may need signature. So if someone's supposed to fill out a consent form or an authorization of some sort by Friday, and they miss that date by 3 days, send an alert, send a reminder, of that exception. So various strategies here that can be employed to support this type of behavior, to support, looking at the data and making actionable interactions based on data that's collected, or even that's not collected. Dr. John, I know you probably have a lot of comments around this, or ideas around this as well.
Yeah, we definitely, when you see the patients as an individual, then you see where the risk is for dropping out of a pathway. or complications occurring, and the ability to circumvent that or prevent it is very valuable. But
Yep.
a lot more I could say, but I'm looking at the time too, and interested in our next polling question.
You're leveraging automated digital interactions just as described with your patients.
So there's a whole lot of digital interactions today, this digital front door and patient portals, but specifically a personalized path of interactions digitally with patients is a great opportunity, wouldn't you say, Rini?
Yeah, no, absolutely. I mean, even simple things like symptom tracking, journaling, right? Medication tracking, meal tracking your meals, different sort of interactions, different sort of interventions that could be enabled. Interesting to see, how many people are using text messaging as a digital interaction, as well as video calls, of which again the pandemic has really driven to a high level. But yeah, there's a number of different tools, a number of different sort of mechanisms that can be implemented to drive all sorts of very interesting digital interactions. And the goal here is to help drive positive behavior change, a positive sort of meaningful encounter that can help both the patient and the clinicians.
All right, so do we have some results?
Okay, interesting. Yeah.
I am interested in the why behind this, and maybe we can get into that if there's any discussion to follow up on this, because we're getting close to the end of our scheduled conversation here. We're getting to the unscripted zone, right, Rini?
Yeah, no, it's just very interesting. Yep.
So just a couple more slides.
Yeah, so just so a lot of ideas here, a lot of technology powered enablement here, but I want to emphasize that it is real, and these technologies do exist, and we've seen success in various implementations around these types of projects, and again Javion has similar successes and case studies around various implementations as well. One program in particular was an opioid addiction treatment program, which is top of mind out in California that we just completed, where previous to a digital implementation, and this slide talks to that opioid program, previous to Moses being implemented, they had a high rate of dropouts. Almost 70 to 75% of individuals dropped out of the opioid program midway. They didn't stay with the program. They weren't engaged. They were missing their meetings, they weren't tracking their symptoms or their medications, and then it was a very difficult program to manage. We implemented digital, right, with virtual care and some apps. Some individuals had apps, phone apps. Some individuals had web apps. Tried to personalize it based on the different cohorts that we had. And we saw a 42% increase in active engagement, right? This includes their check-ins, going to their meetings, the 12-step meeting card that they had, just even filling out food diaries and their daily check-ins on their pains, right? Their daily pain symptoms that they were tracking through the apps. So, definitely better engagement, better usage of technology, and the clinicians were receiving more relevant and timely information around their patients using digital than they did without digital, which then resulted in a decrease in program dropouts quite a bit. So a very successful program, and something that you can directly attribute to sort of a digital health implementation. So that was around an opioid program, but we have a number of other programs with similar results around chronic disease management, where we typically see engagement and retention metrics at around 65 to 75% improvement levels, right? Health outcomes with respect to hospitalizations, we see, again, it depends on the program and the disease state and the cohort, but 30 to 60% improvement or decrease to hospitalizations just through proactive, better connected care through technology. And then various cost efficiencies that we see, around 15 to 25% improvement in staff utilization and just time saved by clinicians through automated data reporting and automated sort of automated nudges and alerts that are more actionable by clinicians. So we real world examples, data. Both Dr. John and I would be happy to share in more detail with you as it results to, or with context to your programs and sort of the disease programs that you may be interested in. I'm sure between Javion and Moses, we probably have a lot of information that we could share that's more meaningful.
Well, a powerful example here, Rini, and I mean we all sense the value for patients that are more proactive, engaged, and attached to their providers. The stickiness of that loyalty is also important to continue to provide continuity of care. And this is a concept of a journey of how to get there. So now we've revisited this this gauntlet of patient engagement, and now it's a clear path, no less straight on the visual, but it's a clear path to get to engage an engaged patient on the other side when these barriers are understood and addressed. So really appreciate everyone's time, and we look forward to taking a few questions or having some discussion. Turn it over to Keely now to guide that part of our conversation here.
Great, thank you guys. So as mentioned, we are going to go ahead and move into the Q&A portion of the webinar now. So if you have any questions, go ahead and put those in the questions box on your attendee panel. We will try to get as many of those answered as we can. If we do run out of time for whatever reason, we will follow up with you directly, as Garrett mentioned at the beginning of the webinar. So there are a few coming in, so we'll just go ahead and get started. The first one is, when talking about analytics, is this model achievable with predictive AI?
Yeah, well, I'll say predictive modeling or predictive AI, literally it allows you to risk stratify, it allows you to predict what will happen, but it falls short in a scenario like this where you're trying to understand, what do I do? So if I want to profile patients or better understand where they are today, predictive modeling will only tell me risk with a particular endpoint, which can be helpful, but it isn't answering this question. And then the hardest question is, okay, so I know a patient is in this profile, or I know that they have risk, therefore, what should I do? And without that, if you remember that slide with all those options on it that Rini went through, you got 50 different interventions I might do or questions I could ask, and I can bury my staff with probing and digging and finding to figure out exactly what to do and create a care plan for a patient. If I don't have some automated AI to indicate, hey, point in this direction, take a look here, and to give some guidance. So guidance is going to be the most important piece of this that predictive modeling does not deliver.
Thank you. So next on the list, how did you identify the barriers to engagement at the beginning of the presentation?
Yeah, those are common representative examples, but we see patients holistically. That are the insights we provide from Javion. We see over 5,000 features about every single patient, and when we have a use case, then to say, okay, we want to, the endpoint is a patient that's engaged or a patient that's disengaged. We will understand at a granular level what are the features that are driving risk, and so these were illustrative of what could be, maybe a dozen or a couple of dozen major categories, and then within that, hundreds of features driving the risk of those categories.
So moving right along, how do you measure the success of a tool or program like this?
I can take that one. So, obviously, when you look at engagement metrics, we look at everything from app downloads or app activation, right? So if there's a number of accounts, how many of those individuals have activated their accounts? And then again, depending on the model, how often do they visit that app to complete something, to interact with that app? So we have, very detailed metrics around app usage. So are they filling out a form? Do they have, are they acknowledging an appointment? Are they doing a video call? How are they using the app? So app usage metrics are really important too. And that's very unique to every program. But we've got the data model that has these dashboards, these engagement dashboards, if you will, that provides a lot of this information. App account activations, logins, app usage, forms that get filled out, interactions that happen, and the frequency of app usage over time, right? So we can capture a lot of engagement data, but then obviously you want to look at outcome data. So for these individuals, how are they getting better? Are they progressing? How many hospitalizations did you avoid or mitigate? Medication adherence. There's a lot of insight you can capture from this information. That can again drive into a database, and then a solution like Javion can further analyze and provide additional prescriptive analytics around. But Dr. John, would you have any additional comments to that?
Yeah, I would say with any endeavor like this, we should look at both, and you described this, Rini, very well, I'd say process metrics and outcome metrics. And we at Javion are also very interested in this concept of a comparative effectiveness research. What we do, we should be able to demonstrate is making an impact. It's making a substantive difference in outcomes. And that's the concept of comparative effectiveness research. So, Rini, you covered the basis, and I just I'm agreeing. So
made it sound better.
Okay, great. Moving on. Is this something that would be managed outside of the EHR?
Yeah, I can take that too. So good question. Yes, it can live outside the EHR. Ideally, the value add is when it is connected to the clinician systems in the back end, and so that end-to-end round trip. But there's a lot of data a system like Mosaz and a system like Javion, that they're collecting and crunching and maintaining. A lot of that information does not necessarily need to go back into the EHR, but clinical records typically do. And so again, they can either live standalone in the Mosaz system, but we also have integrations with over 30 different systems that could be that we can feed information bidirectionally with as well. So using standard integration standards, FHIR, HL7, APIs, it's all possible.
And if I can just add on to that, I've, in my experience, having done dozens of electronic health record implementations in my journey, there's some points here to tease out. For example, the clinical decision support that Javion provides is just intelligence. You can put that in anywhere. You can put it in an EHR. You can put it wherever it's needed. Patients, though, don't live in the EHR. Clinicians do. Patients, metaphorically, they don't intersect with the EHR directly. So a Mosaz type solution will meet patients again where they are in their world, and then that data should be connected somehow, or the results generated feedback in a way that's useful for clinicians to do something differently about. So connectivity is important. Having that information flow is important. Having all of the work, though, embedded in the EHR assumes some things that might not necessarily be true. For example, the patients aren't going to ever go there directly.
Yeah, I would add to that. We always talk about patient engagement, as a key concept, but also provider engagement is another important factor. So provider adoption, provider usage, provider engagement of a solution. Providers are not using the solution, and where they live. Again, the adoption and the usage of that program becomes less successful. So if Dr. John, as you mentioned, if the clinicians live in their EHR, live in their systems, that's really where they should be interacting and viewing the data and doing, managing the program, as opposed to a totally separate system. So both models exist. We can provide both models depending on the maturity level of the organization from a digital technology perspective. But again, another best practice approach we take is, sort of a step-by-step approach. And so you don't want to boil the ocean on day one. So, there's a process to implementation, test it out, all the security framework needs to be in place, and to see if it works, right? Do the technical feasibility and the security assessments, and you can roll it out step by step, an iterative approach.
Great, and being cognizant of time, I think we'll do one more question before we wrap. So for the last question, have you run into issues with patient trust when sending in their health data?
Send in their health data, sure. I mean, so, security and privacy are super important. So you want to make sure, you've got the right, HIPAA agreements in place, you've got the right encryption in place, you've got the PHI and the PII that's protected and encrypted, right? All that needs to be secure, and you've got the right models, the right models in place to ensure that everything is protected, not just from a technology perspective, but also from a process perspective, a people process perspective. You want to make sure that you limit access to various patient information, within your organization, within your company, within a technology provider. And so yes, a lot of that information is really important. Getting the consents, the proper consents in place are also important, right, with the patient. And so a lot of that information becomes critical, and communicating and sharing that with patients and the patient population is very important. So once we do that, once we explain, or once the providers share that the data is protected, we try to, obviously, in a best practice approach, minimize any PHI information that can be exposed to the system. So if a lot of the information can be captured in a de-identified manner and all sort of codified and encrypted, that is a best practice approach. But in certain cases, PHI does need to be captured, but then it just needs to be treated properly and treated securely. Any comments, Dr. John?
None from me for that. Thank you for hitting that square on the head, Rainey.
Great. Well, with that, I'm going to pass it back over to Garrett to get us wrapped up. So Garrett, over to you.
All right. Well, thank you all. Dr. John and Rini, this was just a great presentation. I thought you guys did a fantastic job, very engaging. And so thank you. Lot to think about here. Couple thoughts as we close out here. I wanted to encourage you to visit the Mozaz exhibit booth at acoexhibithall.com. And here's where you can learn more about them and engage with their team. And there's a lot of cool things that you can play with here and just find out more about what they're doing. And also at acoexhibithall.com is where you can find a archive of the webinar itself. So we have a library, it's a reference library. You can actually search for webinars. So it'll be kind of living there indefinitely, but definitely encourage you to come and check out the Mozaz booth there. And then finally, I just wanted to thank again our speakers and thank you all for coming. And if you have any specific questions that you weren't able to answer, or if you want to contact the Mozaz team, their contact information is, Kaylee, if I can have you go to the last slide, it's on this slide here, and then you can feel free to make a note of that, reach out to them, and they'll be happy to follow up with you. So thank you again, stay healthy, have a wonderful rest of your days, and we'll see you next time.
Thank you.
Thanks, Dr. John.
Thank you, Reed.